Hello and welcome to week 13. We are done with the male reproductive system and moving forward into our exploration of the female reproductive system this week. The major organs involved in the female reproductive system are the ovaries, which are the female gonads, the uterine tubes, also called the fallopian tubes, the uterus, the vagina, the external genitalia, which is termed the vulva or the pudendum. That includes the labia and the clitoris, and then the mammary glands, which make up our breast tissue. Mammary glands are considered parts of both the integumentary system as well as the female reproductive system. Each of these organs has their own specific purpose. The ovaries produce secondary oocytes and hormones, including progesterone and estrogen. They also secrete inhibin, which acts similarly to the inhibin in the male reproductive system, which was to go and inhibit the release of gonadotropin-releasing hormone and therefore the release of follicle-stimulating hormone. And they also secrete relaxin, which we will discuss next week in our exploration of labor and birth. The uterine tubes transport the secondary oocyte from the ovary to the uterus, and this is typically where fertilization occurs if fertilization is going to occur. So the uterine tubes are similar to the ductus deferens in the male reproductive system. The uterus is where the fertilized ovum is going to implant and develop into a fetus during pregnancy and labor. The vagina receives the penis during sexual intercourse and is the passageway for the baby during childbirth as well as for menstrual blood during the monthly cycles. And the mammary glands function to synthesize and secrete milk for nourishment of the newborn baby. So looking at this picture, we can see the ovary is up here, and the uterine tube wraps around. Let's do this in a different color. The uterine tube wraps around the ovary and comes down to the uterus like that. I'll erase that so you can see the actual uterine tube. The uterus lies here, and the vagina is below the uterus, opening to the external world. We have the bladder down below the uterus and the urethra leaving the bladder. And then behind the uterus is the rectum back here. Externally, our external sexual organs, we have the clitoris in the front, and then the labia majora and the labia minora down here. And we'll talk about those a bit more in a minute. So you have two ovaries, right ovary and left ovary. They're about the size of a walnut. They're pretty small. And they're attached to the uterus by ligaments. They're also attached to the pelvis through ligament attachment as well. So the ovarian ligament goes from the uterus to the medial surface of the ovary. So that's right here. Oh, let's see. Right here is the ovarian ligament. And the suspensory ligament goes from the lateral ovary over to the pelvic wall. So this is the suspensory ligament here. And the suspensory ligament houses the ovarian artery and the ovarian vein, which come in and attach to the ovary at the hilum. There's also the mesovarium, which is this connective tissue that encases the ovary. And then the broad ligament, which is this wider ligament down here, that's part of the mesentery that suspends the whole female reproductive system. You can see that the ovaries have this lumpy texture to them. That's termed follicular. So they are follicular because they have fluid-filled cavities within the walls of the ovary. Each follicle contains one ova or oocyte, which is that developing egg cell. And traditionally, one egg is released from the ovary every 28 days. That cycle can certainly be shorter or longer in individual people, but on average, it's about every 28 days. The three main functions of the ovary are production of the female gametes, which are oocytes, the secretion of estrogen and progesterone, and the secretion of inhibin for feedback control over the release of additional FSH. The ovaries are also surrounded by a tunica albuginea, much like the testes. And then outside of that tunica albuginea is a germinal epithelium. There is a cortex, so the outside or the outer layer of the ovary is considered the cortex, and then that very inside of the ovary is considered the medulla. Oogenesis is the female version of spermatogenesis. It is the production of an ovum, which would be an egg that's viable for fertilization. And this process begins before the female is born. It accelerates during puberty and then ends at menopause. It occurs on a monthly basis when the oocyte is released from the ovary and travels down the uterine tube to the uterus. When you're born, you have roughly 2 million primordial follicles. So those are the initial oocytes. The primary oocytes are in these primordial follicles, and there are 2 million of them in the female at birth. However, many of them are going to disintegrate or degenerate in a process called atresia. So by the time the female hits puberty, there are only about 400,000 viable oocytes left. Of that, I believe it's about 500 that actually get ovulated throughout the lifetime, and then the remainder of them will also undergo that atresia. Primary oocytes develop before birth, and then they remain suspended until puberty. So nothing's really happening with them until puberty. At puberty, the FSH levels begin to rise, and that triggers the start of the ovarian cycle. So every month, the primary oocyte is going to, one primary oocyte is going to start developing further. And so this is going to undergo the process of meiosis, much like we talked about with the male reproductive system last week. So in meiosis in the female, the difference is that the cytoplasm divides unevenly. So you produce one ovum, which is the secondary oocyte, and 2 or 3 polar bodies. And the polar bodies are just smaller things that end up disintegrating over time. So the polar bodies are just pieces of cytoplasm that come off, and then the one ovum is the secondary oocyte that will actually develop into the egg that can be fertilized. So the ovary is going to release that secondary oocyte, and that secondary oocyte is suspended in the metaphase of meiosis II, and it will not go any further until it is fertilized. So if it gets shed in the menstrual cycle, it will stay in that metaphase of meiosis II. But upon fertilization with a sperm, then it will undergo and complete meiosis. So the beginning of oogenesis is similar to spermatogenesis, where we have mitosis of the original cell that produces one cell that stays and one cell that becomes the primary oocyte. And the primary oocyte is a diploid cell, meaning that it has 46 chromosomes. Then the primary oocyte forms those tetrads, so those groupings of chromosomes where synapsis takes place. So the synapsis is the mixing of maternal and paternal genetic information. And then the primary oocyte during meiosis 1 is going to become a secondary oocyte, and it's going to shed its first polar body. So we have meiosis 1, we have a secondary oocyte, and that secondary oocyte is haploid. So the polar bodies are shedding of genetic material and cytoplasm, but they end up disintegrating over time, whereas the secondary oocyte is what goes on to become our ovum. In meiosis 2, the secondary oocyte is going to progress to metaphase of meiosis 2, and that is where we end up with this mature gamete that can then be fertilized by sperm. It's also going to shed its second and or third polar bodies, and so it ends up with this haploid ovum at meiosis 2. And it's suspended in metaphase of meiosis 2 until it is fertilized by a spermatozoa. Ovarian follicles are the structures where oocyte growth and meiosis 1 occur. They're located in the cortex of the ovaries, and the primary oocyte is within these cells called follicle cells, and they wrap around that primary oocyte. They're in the cortex near the tunica albuginea, and they're clustered in what are called egg nests. So it's multiple follicles clustered together. Like I just said, the primary oocyte is surrounded by follicle cells, and those follicle cells, in addition to the primary oocyte, is what forms our primordial follicle. So that's our very first follicle, is our primordial follicle. Once you undergo puberty, a different group of primordial follicles becomes activated every month, and so one oocyte ends up being shed every month. This ovarian cycle is divided into two phases: the follicular phase, which is the 14 days prior to ovulation, and the luteal phase, which is the 14 days post-ovulation. So step 1 is the formation of primary follicles. So we begin with these primordial follicles, which you can see here, and the follicular cells are going to start to enlarge and divide to form multiple layers around that primary oocyte. Those follicular cells are then called granulosa cells, and the region around the oocyte is called the zona pellucida. And the zona pellucida is a glycoprotein-rich region which helps to sustain that primary oocyte. As the granulosa cells enlarge and multiply, a layer of thecal cells form around the follicle, and those thecal cells, along with the granulosa cells, are where our estrogen are produced. So thecal cells along with the granulosa cells are where estrogen is produced. So in step 1, we have gone from a primordial follicle to a primary follicle. And you can see the difference. The primordial follicle is very small. The primary follicle has this wide band of cells surrounding that primary oocyte. In step 2, we're going from a primary follicle to a secondary follicle. So the wall of the follicle is going to thicken, and the deeper follicular cells, the cells that are deep in the follicle, are going to begin to secrete a fluid, and that fluid is going to make these little pockets. So you can see these little white pockets in here. So those are pockets full of fluid, and they're going to expand and separate the inner layers of the follicle from the outer layers of the follicle. So this is step 2, is formation of a secondary follicle. Step 3 is going to be in the last few days of the cycle. One of those secondary follicles is going to become a tertiary follicle, and the tertiary follicle is also called the mature Graafian follicle. So the tertiary follicle there's the oocyte over on the edge, and then there's this big wide open space inside, which is called the antrum. The antrum is that expanded chamber on the inside of the follicle. The granulosa cells that are associated with that secondary follicle form a protective layer around the oocyte known as the corona radiata. So the corona radiata is right around the oocyte within the tertiary follicle. So here's our tertiary follicle here. These are also called vesicular follicles because this is looks like a large vesicle with that antrum containing all of the fluid. Once the tertiary follicle has developed, then ovulation is going to occur. So ovulation is the release of the secondary oocyte along with the corona radiata from the ovary. The corona radiata is sticky, so it keeps that attachment between the oocyte and the ovary so that the oocyte doesn't just go flying off into space. And then the oocyte gets sort of moved into the uterine tube by these finger-like projections called the fimbria. And the fimbria have cilia in there at the tips of the epithelial cells, and those cilia beat and pull the oocyte into the uterine tube. So this is important. The transition phase of ovulation marks the end of the follicular phase and the beginning of the luteal phase. So remember, the ovarian cycle has the follicular phase and the luteal phase. Ovulation marks the end of the follicular phase and the beginning of the luteal phase. So now we're in the luteal phase, and what happens here is under the stimulation of luteinizing hormone, the granulosa cells that remain from that tertiary follicle are going to collapse, and it becomes filled with cholesterol, and that's what gives it its yellow color. And the corpus luteum is then going to utilize that cholesterol to synthesize mainly progesterone, but also some estrogen. The progesterone becomes the dominant hormone throughout the luteal phase, whereas estrogen was our dominant hormone in the follicular phase. Progesterone works to prepare the uterus for pregnancy because it stimulates the maturing of the uterine lining and increases secretions of the uterine glands to help to sustain that pregnancy. If fertilization does not occur at about 12 days after the corpus luteum has been created, then progesterone and estrogen levels are going to decrease markedly, and fibroblasts are going to invade that corpus luteum and turn it into what's called the corpus albicans, and that is basically like scar tissue that is infiltrating that corpus luteum. The corpus luteum stops producing progesterone, and that marks the end of the ovarian cycle, and then another ovarian cycle is going to start with activation of another group of primordial follicles. So the disintegration of the corpus luteum and the creation of the corpus albicans ends the luteal phase of the ovarian cycle. The uterine tubes are also called the fallopian tubes or the oviduct, O-V-I-D-U-C-T. They are hollow muscular tubes that extend from the upper edges of the uterus toward the ovaries. They're just a few inches long, but they don't directly connect to the ovaries. They don't actually touch the ovaries, but they flare at the ovarian end into a funnel-shaped area with these finger-like extensions called fimbria. So when the egg is released from the ovary, it's still stuck to the ovary from that sticky corona radiata, and the fimbria are going to guide the egg into the fallopian tube. The tubes are lined with cilia, and they also have those smooth muscle walls. So between peristaltic action and the muscle walls and the movement of the cilia, they propel the egg through the uterine tubes down into the uterus. The egg is typically fertilized within the tube toward the uterine end. So almost at the uterus is where fertilization takes place, but still within the tube. Unfertilized oocytes are going to degenerate in the terminal portions of the uterine tubes or within the uterus, and they will never complete meiosis. Remember, meiosis is completed only upon fertilization. The uterine tubes have three sections. The infundibulum is the section that contains the fimbria, that is the closest portion to the ovary. The ampulla makes up the bulk of the tube, so most of that tube coming down toward the uterus. And then the isthmus is a connection that connects the ampulla into the uterus. And that's the portion where fertilization would generally take place, is between where the ampulla and the isthmus come together is the site of fertilization. We have three different kinds of cells within the uterine tubes that are important for us to know. The ciliated cells are numerous in the infundibulum and the ampulla, and estrogen is going to increase production of cilia, and you remember the movement of the cilia helps to move the oocyte down the uterine tube down the ovarian tube, fallopian tube, let's go with that, it is the uterine tube, through the tube toward the uterus. The PEG cells are interspersed down the uterine tube between ciliated cells, and they've got these granules at the end of the apical surface that produce tubular fluid, and the fluid that they produce completes the capacitation of spermatozoa. So if you remember from last week, the spermatozoa are released, but they are still not able to fertilize an egg. And they become able to fertilize only when they come into contact with the tubular fluid that's been released by the PEG cells. So that's an important thing to know. Then there are also mucin secreting cells which aid in lubricating the uterine tubes. The uterus is a thick muscular organ that is posterior to the bladder and anterior to the rectum. It's anchored by three ligaments: the round ligament, which connects to the external genitalia, the cardinal ligament, and the uterosacral ligaments. Those stabilize the uterus and limit its side-to-side movement and superior and inferior movement to really keep it where it belongs. The uterus has three anatomical regions, actually more than three that we're going to talk about. We're going to talk about four. So the cervix is the lowermost region, which opens to the vagina. Above that is a region called the isthmus, which connects, it's a constriction at the base of the body that connects the body down into the cervix. The body is the largest portion, and the body ends at the internal os, which we'll get to in a minute. And then the fundus is the superiormost portion of the body, which is up above the connection of the uterine tubes. The uterus has multiple functions, provides mechanical protection for the fetus, nutritional support for the fetus, removes waste during fetal development, and then constriction of the musculature is going to help to eject the baby during the birth process. The uterine cavity is the large chamber in the center of the uterus. It's continuous with the isthmus of the uterine tube on either side. The internal os is the opening that connects the uterine cavity to the cervical canal. And the cervical canal is a passageway that is at the inferior end of the uterine cavity. It begins at the internal os and it ends at the external os. So those are the two openings between the vagina and the interior of the uterus. There's the external os and the internal os. And the cervical canal is between the two of the two os. The uterine is highly vascular. There are arteries that branch to form arcuate arteries. The arcuate arteries encircle the endometrium. Radial arteries supply straight arteries. Straight arteries deliver blood to the basilar zone of the endometrium. And then the spiral arteries supply the functional zone. So if I was going to have you know any of those, I would have you know the spiral arteries are what are supplying the functional zone of the endometrium. And the functional zone is the portion that is going to disintegrate and be sloughed off every month. We have 3 layers of tissue that make up the uterine wall. The endometrium is the innermost layer. The myometrium is the middle layer, and whenever you see myo, you think muscle, so it is the muscular layer. And then the perimetrium is the outer layer. So here we can see our different layers. You can see the perimetrium surrounds the outside of the uterus. The endometrium is on the inside of the uterus. And then the myometrium is that thick, smooth muscular wall. Within the myometrium, you can see that we have all of this glandular tissue, uterine glands. So we're going to look at each of those layers a little bit more closely. The endometrium makes up about 10% of the bulk of the uterus. It is the innermost layer, and it is a pretty thin layer. It's got a glandular portion that is the main part for conception and the menstrual cycle, is this glandular portion. During conception, the glands and the blood vessels are going to increase in size and become interconnected by fusing with the placenta, or by fusing to form the placenta. And before menstruation, the endometrium has grown very thick, and the blood vessels are very active in that region with the glandular tissue, and so that's all the part that's going to disintegrate and get sloughed off. There are 2 layers of the endometrium. The functional zone, which is the innermost layer closest to the cavity within the uterus, and that's the layer that undergoes the cyclical changes. And then the basilar zone, which is between the functional zone and the myometrium, and the basilar zone remains pretty constant. It doesn't change with the monthly cycle like the functional zone does. The myometrium is that large middle layer of smooth muscle tissue, and it makes up 90% of the mass of the uterus. So it really is, most of the uterus is a giant muscle. There are 3 layers: longitudinal layers, circular layer, and an oblique layer within the myometrium. So you have contraction coming from multiple different directions. The muscles can stretch during pregnancy, and smooth muscle cells can expand in size as well as number during the pregnant state. It contracts during labor to push the baby out of the uterus, and then contracts again to deliver the placenta and help reduce maternal blood loss. If the placenta doesn't detach appropriately, then there can be excessive maternal blood loss, and we'll talk more about that next week. And after pregnancy, it assists in returning the uterus to its pre-pregnancy size by shrinking back down. The perimetrium is a serous membrane that lines the outside of the uterus and is continuous with the peritoneum. It's composed of a very thin layer of squamous epithelia that secrete a serous fluid, which helps lubricate the surface of the uterus and reduce friction from muscular movements of the uterus. The menstrual cycle, or the uterine cycle as it also is called, has 2 phases. The proliferative phase, where the lining of the uterus, the endometrium, is growing and thickening. There's a lot of vascularization and a lot of glandular secretion happening. So this happens every month in preparation for fertilization. So if the egg is fertilized, there's this beautifully vascular glandular region to take care of that ovum, that egg that's been fertilized. The secretory phase only happens if fertilization does not occur. And in the secretory phase, the lining is shed. The blood supply gets cut off to pieces of the endometrium. The endometrium begins to disintegrate and then is shed over a period of 1 to 7 days. And after it's shed, it is then immediately starts to rebuild. So the uterine cycle is typically about 28 days, and day 1 of the uterine cycle begins with the onset of menstrual bleeding. The cervix is that lowest part of the uterus that protrudes down into the upper vagina. It's lined with a smooth mucous membrane, and it's typically a very narrow channel. It does act as a passageway for sperm to enter into the uterus and then get up into that uterine tube for fertilization. And it is also a passageway for blood to exit during the menstrual cycle. It widens during labor to allow for the passage of the fetus. And it also generally acts as a barrier against bacterial entrance to the uterus, except during intercourse, it can open and allow for bacteria to enter, and that is how STDs can occur in women, sexually transmitted diseases. The cervical canal is also lined with a lot of mucus glands, and that thick mucus is impenetrable to sperm until just prior to ovulation. So once the egg is released, the sperm are enabled to move up toward the uterine tube for fertilization. Below the cervix, we have the vagina, which is a muscular, narrow, elastic structure. Elastic is important because the vagina is very distensible, which is good because babies are very large comparatively when they are born. It's about 4 to 5 inches long in an adult woman, and it connects the external genital organs into the uterus. The functions of the vagina are involved in intercourse. It receives the penis during intercourse and acts as a passageway for sperm to reach the ova for fertilization. It is also a passageway for menstrual blood that leaves through the cervix, and then it leaves through the vagina to exit to the external environment. And last, it transports the fetus to the external environment during labor and delivery. Around the vagina, we have bulbospongiosus muscles, which are on either side of the entrance to the vagina. When they constrict or when they contract, it constricts the vagina. These muscles cover vestibular bulbs, which are masses of erectile tissue on either side of the entrance to the vagina. And so they do get firm with, they're filled with blood during sexual intercourse. And the vestibular bulbs have the same embryologic origins as the corpus spongiosum of the penis. The vagina typically does not have any space inside. It's collapsed and appears like an H shape on in slides. However, it does stretch during intercourse and childbirth. The lower 1/3 of the vagina is surrounded by smooth muscle, which controls the opening and contracts rhythmically during orgasm. The lining of the vagina is a non-keratinized stratified squamous mucous membrane that is kept moist through fluids that are seeping out of the cells on its surface and by glandular secretions. So we have fluid that is just leaving the cells in the vagina that is going to be lubricating, and then actual glandular secretions, which are also lubricating. During the reproductive years, the lining of the vagina folds and wrinkles. Pre-puberty and postmenopausal, the lining is very smooth. The hymen is a small mucous membrane that partially blocks the opening of the vagina. It assists in protecting the genital tract, but it's not really necessary. Nothing really happens when it's gone, but it is there in birth and pre-intercourse. It's traditionally broken during the first sexual intercourse, but it can also be broken with exercise, with insertion of a tampon, or through a pelvic exam. Sometimes when it tears, it causes bleeding. Other times it does not. The external genitalia functions to protect the internal genitalia and genital organs from infectious organisms as well as from trauma. The vulva or pudendum is the entire area covering the female external genitalia. The vestibule is the area that is surrounded only by the labia minora. So the vestibule is in this area. Maybe I'll do that in a different color. This area in here is considered the vestibule. Other portions are the labia majora, the labia minora, Bartholin's glands, and the clitoris. The labia majora, which are on the outside here, enclose and protect the other external structures. They have fat accumulations in them, so they're larger and kind of fleshy and are comparable to the scrotum in the male. They have sweat and oil secreting glands, and the externally are covered by thick hair after puberty, but the internal surface is smooth. So the external surface has hair, the internal surface is hairless. The labia minora are these smaller folds inside the labia majora that protect the vagina and prevent entry of infectious diseases and foreign organisms, and surround the opening to the vagina and the urethra. The greater vestibular glands, which are also called Bartholin's glands, secrete a mucus-filled secretion that assists in sexual intercourse, and they secrete during sexual arousal. So when the female is sexually aroused, these Bartholin glands or greater vestibular glands are going to increase their secretions. They're located right beside the vaginal opening, so they assist in lubrication during intercourse. These glands have the same embryologic origins as the bulbourethral glands, which, if you remember back from last week, give that pre-ejaculate and assist in lubrication from the male side. The clitoris has erectile tissue, which is comparable to the corpora cavernosa of the penis. It is part of sexual arousal, and it can become erect when stimulated. It has a prepuce, which is similar to the foreskin, that is a fold of the labia minora that covers over the top of the clitoris. And like I said, it becomes engorged with blood during sexual arousal. Female sexual arousal has many similarities to male sexual arousal. Begins with parasympathetic activation, which engorges the erectile tissues and increases secretions of the mucus glands and the greater vestibular glands. Blood vessels are going to dilate and blood is going to fill in those vaginal walls, causing erection of the tissues surrounding the vagina. And the female orgasm is accompanied by peristaltic contractions of the uterus and the vaginal walls, in addition to contractions of the bulbospongiosis and the ischiocavernosus, much like the male orgasm. The interesting thing about the female orgasm is there is little to no refractory period. So whereas the male had a refractory period where they could not induce another erection for a second orgasm, females have little or no refractory period and they're able to have multiple orgasms in a row. There are many hormones that interact to regulate these cycles within the female. So some of them are very similar to males and some are a little bit different. Gonadotropin releasing hormone is secreted from the hypothalamus, and in females it pulses. So in males, remember, the pulse frequency remains the same at all times. In females, the pulse frequency of gonadotropin releasing hormone is increased by estrogens and decreased by progestins. So it changes throughout the month and changes the different pulsations are what cause secretion of additional FSH or secretion of additional luteinizing hormone. Follicle stimulating hormone, which is released from the anterior pituitary, is stimulated by gonadotropin releasing hormone, and it's stimulated when the gonadotropin releasing hormone is pulsing at about 16 to 24 times per day. So that is a slower pulse rate, is going to increase the stimulation of follicle stimulating hormone. And that is mainly during the estrogen dominant follicular phase of the ovarian cycle. Whereas luteinizing hormone is going to be secreted at a higher pulse frequency of gonadotropin releasing hormone. And this happens during the luteal phase of the ovarian cycle when progesterone is dominant. Estrogens in females are released by the granulosa and the thecal cells, as well as the corpus luteum to a smaller extent. Estrogens work to stimulate luteinizing hormone secretion at high levels. They can actually inhibit luteinizing hormone secretion at low levels. It also works to develop and maintain secondary sexual characteristics and sexual behavior, stimulate the repair and growth of the endometrium, and increase the frequency of gonadotropin releasing hormone pulsation, which would then increase the stimulation of luteinizing hormone. Progesterone, or progestins, are also released by the granulosa cells, and the corpus luteum is the main area of secretion of progesterone. It's stimulated by luteinizing hormone, and progesterone stimulates endometrial growth and glandular secretions, which, if you remember, are going to prepare the uterus for pregnancy. So progesterone is really focused on preparing the uterus for pregnancy. And then inhibin in the female is produced by the granulosa cells of the ovary, and what it does is it inhibits the secretion of follicle stimulating hormone. This slide is just showing us that our steroid hormones are all derivatives of cholesterol. So cholesterol can be broken down and then created into progesterone, into testosterone, or into other estrogens, and then testosterone can be broken down into estradiol, which is our main estrogen. The ovarian cycle and the uterine cycles have to operate in synchrony, which means that they are going on at the same time and the same things are happening at the same time every month with each cycle. If those two cycles get out of coordination, that's going to result in infertility. Gonadotropin releasing hormone in the female reproductive system, much like the male reproductive system, is going to leave the hypothalamus and then regulate the production of follicle stimulating hormone and luteinizing hormone. In men, the gonadotropin releasing hormone is released at the same pulse all the time throughout their life. In women, the release changes throughout the ovarian cycle. At about day 14 of the cycle, there's a massive surge in luteinizing hormone. The luteinizing hormone surge triggers the completion of meiosis I by the primary oocyte, the forceful rupture of the follicular wall, and the release of the primary oocyte, which is called ovulation. Ovulation occurs about 9 hours after that luteinizing hormone peak. And then the formation of the corpus luteum also occurs at that same time. Once ovulation occurs, that tertiary follicle then turns into the corpus luteum. Remember, the corpus luteum is going to secrete progesterone, and the progesterone is going to prepare the uterus for pregnancy. So if we look here at our hormonal regulation, we have the hypothalamus releasing gonadotropin releasing hormone. at low levels, at a low rate of release, we're going to stimulate the production of follicle stimulating hormone, which is going to create the follicles to be stimulated, right? Then so follicle stimulating hormone is going to secrete estrogens. The estrogens are going to affect the central nervous system, affect bone and muscle growth, maintenance and establishment of female secondary sexual characteristics, accessory glands, maintenance, and stimulation of endometrial growth and secretion. With additional follicle stimulating hormone is going to give feedback over the production, or inhibin is going to feedback and inhibit the production of follicle stimulating hormone and also inhibit the release of additional gonadotropin releasing hormone. At higher frequency of release of gonadotropin releasing hormone, we're going to stimulate the production and secretion of luteinizing hormone. Luteinizing hormone is going to stimulate the secretion of progesterone by the corpus luteum. The corpus luteum is going to stimulate endometrial growth and secretion and make the uterus ready for pregnancy. And it will also feed back on the hypothalamus to eventually decrease the release of gonadotropin releasing hormone. On page 1089 of your textbook, there's a really great explanation of the hormonal regulation of the female reproductive system. And this is one of the pictures from there. So this is showing us the two different phases of the ovarian cycle. So we have the follicular phase followed by the luteal phase. So the first one is showing us gonadotropin releasing hormone pulse frequency. So it begins at a low level, which is stimulating the release of FSH. And then the level is going to gradually increase throughout the follicular phase, and that increasing level is going to slow down the release of follicle stimulating hormone, and when it gets to a critical point up here, it's going to release a surge of luteinizing hormone. That surge of luteinizing hormone is what triggers ovulation. And after that surge, luteinizing hormone is going to decrease again, and the pulse rate is going to decrease in gonadotropin releasing hormone. The follicle during these stages in the follicular phase, the follicle is developing from the primary to the secondary to the tertiary follicle, and then ovulation is going to occur along with this surge in luteinizing hormone. Then that follicle is going to turn into the corpus luteum, which will sustain for about 12 days, and then the corpus luteum is going to degrade into the corpus albicans if fertilization has not occurred. At the same time, we can also look at our estrogen, progesterone, and inhibin levels. So during the follicular phase, estrogen is our dominant hormone. You can see that up here. And then during our luteal phase, progesterone is our dominant hormone. So estrogen peaks until ovulation, and then estrogen levels start to fall as progesterone levels are increasing, and then progesterone and estrogen levels decrease at the end of the cycle of the luteal phase to then begin the follicular phase again. Our endometrium goes through a lot of changes during this cycle as well. So during the beginning of the follicular phase, that is where we are in our menstrual cycle. So the functional zone of the endometrium is degrading and breaking down and being shed off. Then at about 7 days, the endometrial lining has completely been shed, and it starts to regrow again and regenerate. And then it grows and grows and grows through the luteal phase, preparing for pregnancy. And if pregnancy does not occur, then we get back to the beginning here and slough off again. Another interesting change that we can note in the body during this cycle is the basal body temperature actually changes with these changes in hormones. So your basal body temperature is the temperature of your body in the morning when you wake up before you get out of bed. So if you're going to utilize this method of trying to track changes in hormones, you want to take your temperature before you get out of bed in the morning. So during the follicular phase, temperature is pretty steady. And then just before ovulation, your temperature is going to drop about a quarter of a degree, or yeah, about a quarter of a degree. And then right after ovulation, your temperature is going to go up about a half a degree Fahrenheit. And that increase is going to be sustained throughout the luteal phase. If implantation or fertilization and implantation occur, you will sustain that higher temperature because you have that higher progesterone level in your body. However, if fertilization and implantation do not occur, then your temperature is going to drop back down, and at the beginning of the menstrual cycle, your temperature will be low again, and it will remain low until fertilization occurs again. Some couples use this cycle as contraception. They're looking at temperature, knowing that the spike in temperature occurs during ovulation. So once the temperature drops, or ideally a day or two before that, you would cease intercourse, and then you would wait again until that. So like this would be sort of your safe zone for intercourse without creating a pregnancy. That is not the ideal way to keep pregnancy from happening, just to put that out there. So this slide is just reiterating what I was just saying about the basal body temperature. Breast tissue is made up of modified sweat glands containing mammary glands which produce milk. Milk is secreted to nourish the infant in a process called lactation. The lactation is controlled by hormonal regulation of the reproductive system and the placenta. So a lot of progesterone is going to help stimulate lactation. The breast tissue, these glandular tissue, lies in the pectoral fat pads just under the skin of the chest. The size of breast tissue in the non-pregnant person is predominantly just due to the amount of fat in these pectoral fat pads. Once pregnancy occurs, then breast tissue is going to grow in size from the glandular secretions. Each breast has a nipple, which is where the ducts from the mammary glands are going to come and leave the surface of the tissue, so a baby would nurse from the nipple. The areola is the reddish-brown skin that surrounds each nipple. Mammary glands are drained of milk through the nipple via the lactiferous ducts on each lobe. The milk is located in the back of the breast, but the suckling of the infant actually pulls the milk forward and causes contraction of smooth muscles within those glands to propel the milk forward into the ducts and out through the nipple. There's connective tissue within the breast full of collagen and elastin. There's a fair amount of adipose tissue, and then our suspensory ligaments are connective tissue which originate in the dermis overlying the breast and then penetrate in through the breast to separate the glands into lobules. So here's a picture. You can see the pectoral muscle down here underneath, all of the fatty adipose tissue of the pectoral fat pad. The white here are the suspensory ligaments, which you can see are going and actually entering that pectoral muscle and holding tightly, beginning toward the nipple and then separating the mammary gland into these separate lobules here. Breast development results from estrogen during puberty, the menstrual cycle, and then during pregnancy. With pregnancy, breasts are becoming larger. You have hypertrophy of the mammary glands because of the presence of prolactin, and the nipples may also increase in size and darken in pigment. As with all other systems, we have the bad news of our effects of aging on the system. Women undergo menopause typically between the ages of 45 and 55. Menopause is where ovulation and menstruation cease. Prior to menopause, there's often a period of perimenopause where cycles become more irregular. There is a shortage of primordial follicles, which is the underlying cause of menopause, that the primordial follicles have all degenerated, and so there is no longer anything to actually ovulate. Menopause is accompanied by a decline in estrogen and progesterone, with a sharp rise in gonadotropin-releasing hormone, follicle-stimulating hormone, and luteinizing hormone. These surges in luteinizing hormone are what is attributed to hot flashes that women often undergo during perimenopause and menopause. Hot flashes are usually occurring while estrogen is declining, and then they usually complete when estrogen reaches its minimal levels. Also during menopause, we have decreased size of the uterus and the breast tissue, higher risk of osteoporosis, higher risk of cardiovascular disease, anxiety, and depression. These can be treated with hormone replacement therapy, which is traditionally estradiol. However, they recommend not using hormone replacement therapy for more than 5 years because it increases your risk of breast cancer, cardiovascular disease, and many other side effects that you're not really looking for at the end of your life. So that concludes our look into the female reproductive system this week. Next week, we're going to finish with a look at pregnancy, labor, and delivery, and there's going to be a documentary for you to watch on the miracle of life, which is a really nice way to end our entire exploration of anatomy and physiology. So pat yourselves on the back. You have one more week to go and you will have finished A&P 2 for good. So I'll see you back here next week, and we'll get you headed out on your way to an exciting new career in medicine. All right, have a great week, everybody.